VA health care system. The 5 bills we will discuss today are draft legislation, the Long-Term Care Veterans Choice Act, H.R. 1443, the Tinnitus Research and Treatment Act of 2013, H.R. 1612, to direct the Secretary of Veteran Affairs to convey a parcel of land in Tuskegee, Alabama to Tuskegee University, H.R. 1702, the Veterans Transportation Service Act, and H.R. 2065, the Safe Housing for Homeless Veterans Act. From ensuring the safety of homeless veterans residing in VA homeless grant and per diem facilities to ensuring that veterans eligible for VA paid nursing home care are able to receive care in certified medical foster homes should they choose, these 5 bills address a number of critical issues facing today's veterans and all of us charged with caring for them. I'm eager to discuss each of these proposals in depth to ensure a thorough understanding of their purpose, intended benefits, and unintended consequences. I'm grateful to my colleagues who sponsored these bills and to our witnesses for being here to discuss them with us. I look forward to our conversation. With that, I now yield to Ranking Member Brownlee for any opening statement she may have.
Thank you, Mr. Chairman, and we do have 5 important bills here today and look forward to the discussion. And to allow maximum time for that discussion, I'll limit my opening remarks primarily to H.R. 1443 and H.R. 1702. H.R. 1443, the Tinnitus Research and Treatment Act of 2013 is offered by Ranking Member Michaud. According to the VA, tinnitus is the #1 service-connected disability for veterans from all periods of service, affecting over 840,000 veterans. Since 2005, the number of veterans receiving service-connected disability for tinnitus has increased by at least 15% each year, and the VA has been paying out over $1.2 billion annually to veterans for tinnitus disability compensation. At the current rate of increase, service-connected disability payments to veterans for tinnitus will cost $2.26 billion annually by 2014. Nevertheless, only about $10 million is dedicated to researching tinnitus in the public and private sectors. H.R. 1443 will allow for appropriate research time and resources by directing the VA to recognize tinnitus as a mandatory condition for research and treatment by the VA Auditory Centers for Excellence. This will make certain that research is conducted at the VA facilities on the prevention and treatment of this condition, and that the VA cooperates with the Department of Defense's Hearing Center of Excellence to further research on tinnitus. H.R. 1443 would ensure that we remain on the cutting edge for research and treatment of this issue facing veterans of all ages. Next, H.R. 1702, introduced by Mr. Barber of Arizona, would permanently authorize the VA to operate the Veterans Transportation Service, which provides transportation for individuals to and from the VA medical facilities in connection with vocational rehabilitation, counseling, examination, treatment, or care. VTS was launched in 2010, and the VA's current authority to operate the program is set to expire in January of next year. I did want to emphasize the critical need for this legislation in helping to increase access to care for those who would otherwise face challenges in getting to and from their appointments at the VA. I also wanted to highlight that VA has estimated VTS to save up to $19.2 million in fiscal year 14 and $102.7 million over 5 years, because it's less expensive for the VA to hire drivers through VTS than to contract with ambulance services and or to provide mileage reimbursement. So this is simply a common sense initiative. Thank you, Mr. Chairman, for including these bills in the agenda, and I look forward to hearing the views of our witnesses on the legislation before us today. And I yield back my time.
Thank you. The chairman of the full committee, Jeff Miller from Florida's 1st Congressional District, will be joining us later this morning to discuss his draft legislation, the Long-Term Care Veterans Choice Act. I'll yield to him when he arrives. In the meantime, it's an honor to be joined by my friends and colleagues Mike Rogers, representative from Alabama's 3rd Congressional District, and David McKinley, representative from West Virginia's 1st Congressional District. Thank you for your leadership on behalf of our veterans and for being with us this morning to discuss your proposals. It's an honor and pleasure to have you here this morning. I'd like to mention for the record that Mr. Barber will not be with us today due to the tragic circumstances that have taken place in Arizona, and our thoughts and prayers are with the families of the first responders there who have perished. Their loved ones are true heroes, and their sacrifice will never be forgotten. Mike, we'll begin with you. Please proceed with your testimony. You have 5 minutes.
Thank you, Mr. Chairman and Ranking Member Brownlee. First, I want to thank the chairman and the staff for holding this hearing. I also want to thank the full committee chairman, Jeff Miller, for his leadership on behalf of our nation's veterans. Mr. Chairman, H.R. 1612 will benefit the Department of Veterans Affairs and the people of Tuskegee, Alabama. In 1922, the board of Tuskegee University voted to donate 300 acres of land to the federal government for a veterans hospital. Since that time, Tuskegee VA Hospital and Tuskegee University have grown into integral parts of the community and serve important roles for our nation. Now, as the VA refocuses its mission to better serve our veterans, some of the donated land near the university's campus no longer fits the VA's needs. My bill would transfer back 64.5 acres of land at 2400 Hospital Road back to Tuskegee University so that the land can better serve the community. This transfer also creates new opportunities for the VA by reducing substantial overhead and maintenance costs and providing cooperative authority to leverage the strengths of both institutions. This bill is supported by the VFW, the Vietnam Veterans of America. Both organizations know well Tuskegee's place in our history, and I appreciate their continued support for the community. Thank you again, Mr. Chairman and Ranking Member Brownlee, and with that I will yield back.
Thank you very much. David?
Thank you, Mr. Chairman. And Ranking Member Brownlee and the rest of you on the subcommittee, thank you for holding this hearing. I appreciate the opportunity to give these remarks about 2065, called the Safe Housing for Homeless Veterans Act. This is the same bill that we passed last year, slightly modified, but it's essentially the same bill for the homeless. Currently, there are over 2,100 community-based homeless veterans service providers across the country, and many other homeless assistance programs that have all demonstrated an effort to try to take care of our homeless veterans. I visited some of these shelters throughout West Virginia, not only in my district but elsewhere. You have to understand my background. I come from the construction industry. I'm one of 2 licensed engineers in Washington, in Congress. So it doesn't take me long to walk into a building and I can tell you whether or not that building meets code. And when I walked into some of these shelters, I was appalled at what we've done to our veterans. They have been in harm's way, and they come back, and their lives are challenged in some of these facilities. There is no current law. There's a policy within the VA to comply with the code. Think about that. It's a policy, not a requirement. It's a policy. I think this is an omission governing our Veterans Homeless Program funds. 2065 would require that any organization that seeks funding for VAs for services to homeless veterans to have documentation that their building meets or exceeds building codes. Not a policy, it shall. Before we entrust these men and women, given their lives or sacrifice their lives, they can have a safe home. Makes it easier for facilities to be certified as we open up these requirements beyond just the Life Safety Code, which is 101, NFPA 101, to International Building Code and the fire codes of other versions of these codes. Essentially what the local jurisdiction has adopted. Work with them but make it a requirement, not a policy. Furthermore, the legislation would require adding a section of VA annual report to Congress that would report the number of grant recipients or eligible entities who have submitted a certification that their facility will meet all building codes. I understand there is some concern over their undue burden for these facilities, but as you'll see in the questions, I'll be able to expound a little bit further about that's not quite accurate. When you travel, do your research in other facilities around the country, annual inspections are expected and demanded, and it's not an undue burden. In West Virginia, it's at no cost to the facility provider to have an inspection done to see that you're in compliance. I am pleased that I want you to know that we've already begun our discussions with those individuals that may have some concerns with this, particularly the VA and others that may have a concern that we're undue burden. Quite frankly, folks, Mr. Chairman, I'm more interested in the veterans than I am about bureaucracy. If we're going to put these men and women in harm's way, I want to take care of the problem. And if it costs us $100 a year to have an inspection, then that's the least of my concerns. These men and women deserve to have a focus for them so that when they come home and they have, for whatever the circumstances are, that they have to live in a homeless shelter, they should feel comfortable that they're going to wake up in the morning and there's not going to be a catastrophe wrapping around them. So with that, I yield back my time and hope that we have an opportunity to have further discussion, and I hope you'll be able to support this effort to take care of our homeless veterans. Thank you.
Thank you, Mr. McKinley. I'll now yield to Ms. Brownlee, who will provide testimony on H.R. 1443. No? Proceed with the questions. I think I'll start out. Mr. Rogers, what's the key benefit for this piece of legislation?
Well, it's twofold. The university needs the land back for its expansion, but more importantly, the VA doesn't need, and it's just been a maintenance burden for them financially. There's a large part of their campus that has not been used for years. It's deteriorating. They're going to have to spend money to either bring those buildings back or at least make them safe or tear them down, and they don't really want to do either.
So there's like some unused buildings there then? They're not.
It's exactly what it is, as well as land.
And does the university have plans to do something right away then?
Not right away, but they would like to use it for long-term plans.
All right, thank you. Mr. McKinley, I appreciate your continued advocacy on this issue here, and I completely agree with the need for a safe shelter. Can you comment on the scope of the problem and tell me what you see as the lack of VA oversight there?
Thank you. I don't want to speak necessarily for the VA. I think they can speak for themselves, but I think it's my understanding that there is an effort. They think they're handling these issues internally. They may believe that, but again, my training, and I started in construction in 1965. Think about that at the age that gives me away a little bit, doesn't it, Ms. Brownlee? But it does take me long to understand there was a violation. And if they, Chairman, have that knowledge, then why didn't they correct it? Example could be down in Atlanta. We have from the Joint Commission this report in Atlanta that says Atlanta was supposed to take care of their facility. That there are violations that are listed on page 9. Insufficient compliance on meeting requirements under the NFPA 101. 101 is life safety. Under the door category, insufficient compliance. Space around pipes, conduit where fire and smoke and gas is insufficient compliance. I could go on. But here it is a facility that should have the knowledge, and they're not fulfilling that. We have examples around the country of fires.
Can I ask a question?
5 people were killed in a Texas shelter.
Mr. McKinley, let me ask you this question.
I could go on. They're just the examples like that, Mr. Chairman,
Could-
of examples of where people have not followed the code. They either a wink and a nod, but there are people that are dying every day, and there's needless deaths that are occurring or hurt or harm coming to individuals because they are not following the building code.
Can you give me a couple of examples of the things that you saw yourself when you were there? I mean, you mentioned that you were an engineer and you noticed some things right away. What were some of the things that you noticed?
I've seen lack of sprinkler systems, and I know that if you're going to have a combined, where you have counseling and housing, there is a requirement to have a fire separation, a 2-hour separation, as well as sprinkler systems required by 101. Not what's happening. I can, in time and time again, you're fortunate if you get an alarm system. I saw doors that are not rated. When I mean rated doors, you can have ratings that maybe have to be as long as 2 hours before the door will burn. Before it can, I can tell you, these doors were not rated because on the inside panel on the door, Doc, there's a chip that's affixed there, a little label, and it'll tell you whether it's labeled. I went through, I don't know how many facilities, and I've looked for those labels, and they're not there. We see fire exit ways. They're supposed to be lit. There are strobe lights that were not there at these facilities. These people, Mr. Chairman, are trying to help out the veterans. But in so doing, they're cutting corners. And I just want them to comply with the standards. This is not going to cost the VA one additional dollar. But the owners of these facilities are going to have proper compliance with the code, not a wink and a nod, but so our men and women are safe when they go to bed at night.
Thank you. Ranking Member Brownlee, do you have any questions? No. Dr. Luis?
Thank you both for your work and your support for veterans. I have a question for you, Honorable McKinley. The veterans, how many, do we now have a sense of how many go to veteran-specific shelters versus general homeless shelters?
That's a fair question. No, I don't know. It's just a troubling statistic that anyone winds up in a homeless shelter. But when I've talked to some of them that are there, keeping it certainly anonymous to keep their identity, just for whatever's happened. Whether it can be they're having post-traumatic, they can't keep a job, they've lost their family life because of their issues, series of issues. They're just, unfortunately, they're there. Yeah. The VAs don't have the bed capacity to be able to keep them there, so they're providing space for them here I guess a per diem basis for them to be able to stay at these facilities. So I don't know how many would be there in a VA sponsored versus one that might be in a non-veterans homeless shelter. But I can tell you, Congressman, I'm seeing the problems in both. It's not just the VAs. The VAs, I think, want to do what's right, but they want to use a policy. I think we ought to make it statutory so that it doesn't vary from state to state to state and municipality, whether it's a wink and a nod that they'll let them stay there. Let's give people ability to have a safe housing, and whether they're in a public one or in a VA-sponsored facility.
Yeah, that's the point of my question, was to figure out if, our primary concern with this bill is to make sure that veterans themselves have a safe place to rest, given the special covenant that we have with our veterans. And in general, we should strive to make sure that any homeless could have a safe place to stay at night as well. But in this special case, if the majority go to private or nonprofit shelters, which is usually the case, the nonprofit organizations, then my concern is, are we still reaching out to those homeless shelters for them so they can have their place to sleep?
in my jurisdiction, in the First District of West Virginia, whenever I see one of these in a non-VA related facility, I talk to the municipality about whether or not to make them in compliance.
Okay.
But we don't have jurisdiction over those facilities. We have the jurisdiction where there's federal money being used to help these individuals. That's why I'm dealing with it here, but I'm dealing with the other in another matter. And it has to be done on case by case, municipality by municipality.
Thank you very much.
Thank you.
Ms. Kuster, do you have any questions?
Just briefly, thank you very much. Thank you very much for your testimony and for bringing these bills forward. And I just want to address a question to Mr. McKinley. And you seem well versed in this, so I just want to understand. I've worked in the past in my state of New Hampshire with colleges and universities in dormitories and housing and trying to comply with local codes. And I know that there's a distinction between the international building and fire codes and the life safety codes.
Yes.
And I'm just wondering what the impact. I agree with your intent, and I want homeless veterans to be in safe conditions. In New Hampshire, the facilities that I've seen have been very safe. But my concern is not to add to the burden and have an unintended consequence of inadvertently making housing less available to homeless veterans. So if you could comment on how this will work with the international code, the health and safety, the life safety code, and the various local approvals that might be required.
See how to try to answer that.
For the layperson.
If it's a, we took it some time yesterday, and I think they also began on Friday, trying to contact some other states to find out how they deal with these shelters. Because if the concern is over the $100 or whatever they cost, $200 or that's if that's going to be a burden,
We can deal with it.
think about it. Think about that. An annual
Yeah.
cost of $100 spread out over your facility, or $200. We found out again in West Virginia, those inspections to see that they're in compliance are done at no cost. In Virginia, they have an annual state requirement. No one is complaining about it in Virginia. In New York, there's an annual local level for all publicly accessed buildings. And Utah performs the same thing of fire safety. In fact, they make in Utah, they have to fill out this 60-page document every year to give everyone a comfort level that the buildings are safe and that we can put human occupants in that building and they can walk out the next day. So I think the little bit of burden of having to do paperwork once a year, I think is certainly appropriate, given that we're putting people that they're hurting emotionally, give them the comfort that their living conditions, their environment, that they'll be safe. And I think we'll find, if we continue doing the research, we'll find that all across America there are those requirements, either to comply with life safety, the 101 and the National Fire Protection Agency, or some of these other codes, the ICC, which is generally observed for most of the states around the country. But I think every state has to comply with the NFP 101.
Okay.
That's
Thank
all
you.
we're asking for here. Don't make it a policy.
Mm-hmm.
Make it a requirement when they get their license every year. And it may not cost anything depending upon your state.
Yep. Okay. Thank you very much. I yield back.
Mr. Hillscamp, you have any questions? Well, thank you. Thank you again for coming, and since there's no further questions, the first panel is now excused. Welcome our second panel to the witness table. Joining us on the second panel is Mr. Jacob Gadd, the Deputy Director for Healthcare for the Veterans Affairs and Rehabilitation Division of the American Legion, Dr. Susan Shore, Chair of the Scientific Advisory Committee for the American Tinnitus Association, Mr. Adrian Atizado, the Assistant National Legislative Director for the Disabled American Veterans, Robert Drexler, Member of the Board of Directors for the International Code Council, and Mr. Raymond Kelly, the Director of the National Legislative Service for the Veterans of Foreign Wars. Thank you all for being here this morning and for your hard work and advocacy for our veterans. I appreciate you coming here to present your views on of your members, and I would anticipate your testimony with eagerness. We'll begin. Mr. Gadd, please begin your testimony. You have 5 minutes.
On behalf of the 2.4 million members of the American Legion, I'd like to thank you, Chairman Minashek, Ranking Member Brownlee, and members of the committee for the opportunity to provide comments on these health care bills. H.R. 1702 is needed to ensure that Veterans Transportation Service Program is authorized as a permanent authority. For years, VA transportation programs and initiatives have been viewed as an ancillary or secondary service area, but the American Legion recognizes that veterans transportation programs are vital and often the difference between whether a veteran is seen for care or not. VTS originated as a VA transformation initiative to ensure veterans with serious injury, illness, and those who live in remote areas receive travel. In May 2012, VA General Counsel rendered an opinion which found that VA only has the authority to use volunteer drivers to provide veterans transportation to and from VA health facilities, not paid employees. The American Legion became involved after the General Counsel ruling, as we had just finished up our System Worth Saving report on rural health care. In this report, we visited VA medical centers and hosted town hall meetings with veterans to understand firsthand what challenges veterans face in highly remote areas, such as in Maine, Kansas, Missouri, New Mexico, and Wyoming. We found that for many veterans, driving in long distances were a disincentive and barrier to them receiving care. We found that VTS was a viable solution as it offered veterans a secondary option to supplement current VA transportation programs. We found concerns with VA's current organizational structure of transportation programs in VA medical facilities, which is fragmented and disjointed, with different transportation programs located throughout the hospital instead of in one central place. Based on the findings of the report and in response to VA's General Counsel ruling, the American Legion adopted Resolution 293, the Veterans Transportation System and Benefits Travel. This resolution urged VA to establish a transportation department within each VA medical center to coordinate and oversee all transportation programs in the hospital, such as conducting transportation catchment analysis, Veterans Transportation Service Program initiatives, volunteer transportation drivers, beneficiary travel programs, and valet programs. As one veteran recently told us in Nevada, veterans travel as far as 200 miles to the VA Medical Center for required appointments, as the service is not available in their C-Box. These van pools require them to leave their residence very early in the morning and not return home until later in the day. Due to medical conditions, not all veterans can withstand this type of travel and instead take their personal vehicles. A number of these veterans are subjected to a fixed budget and often find the cost of travel for medical care a rather large burden. Veterans have a choice where they want to receive their health care. If their transportation needs are not met or fulfilled by VA, they may not receive care at VA, or worse, not receive care at all. The American Legion supports this legislation, but urges this committee to include provisions requiring the VA to establish veterans transportation departments within VA medical centers to maximize coordination, efficiency, and availability of transportation options for veterans. Regarding draft legislation on the Long-Term Care Veterans Choice Act, while the American Legion does not have an official position on medical foster programs, we have noted VA's trend in several years of reducing institutional care beds in lieu of other community options. American Legion Resolution 121 has three actions that we stated. VA be required by the 1998 Millennium Healthcare Act to maintain and restore its in-house nursing home capacity to 13,391 beds. Second, that VA create incentives and receive appropriate funding to maintain its nursing home beds rather than abandon them to alternative sources. Third, that Congress appropriates sufficient funds to support the provisions of the Millennium Healthcare Act so VA is not forced to reduce its nursing home care unit capacity. Understanding that not every veteran requires long-term care or skilled nursing in an institutionalized setting, it's important to the American Legion and America's veterans that the availability is there if the need in the VA exists, particularly as the number of World War II veterans and Vietnam veterans needing skilled care is poised to increase over the coming years. Now is not the time to be reducing capacity or availability of long-term care. The consequence of not having availability of long-term beds is that state veterans homes and other non-VA long-term care options will be overtaxed and unable to admit veterans patients. Once again, American Legion thanks you for this opportunity to testify on these important bills today.
Thank you very much. I appreciate your testimony. Dr. Shore, why don't you please start?
Good morning. Thank you for this opportunity to give testimony on H.R. 1443, the Tinnitus Research and Treatment Act of 2013. Good morning, Chairman Benishek and Ranking Member Brownlee and the rest of the distinguished members of the Health Subcommittee. My name is Dr. Susan Shore, and I'm the chair of the Scientific Advisory Board for the American Tinnitus Association, often called ATA. This is a very important issue, the issue of tinnitus, sometimes pronounced tinnitus, and it's especially important because it's often ignored as it's viewed as an invisible disorder. An invisible disorder because nobody but the people who are suffering from it know that it's there. It's a subjective phenomenon. And because of this, I think this is one of the reasons that it's underfunded. So on behalf of the ATA and the 50 million Americans afflicted with tinnitus, I'm going to give you some background on why I think it is so important to get more money for research. So the ATA funds research grants, and it's the only member-based and nonprofit organization dedicated to finding a cure for tinnitus in the United States. Since 1980, we've funded grants towards better understanding of the mechanisms that are responsible and underlying the genesis of tinnitus. The advances in tinnitus research over the past decade have been extraordinary. One of the most important advances has been the ability to visualize tinnitus through the use of advanced functional imaging technologies and also through the development of animal models that can behaviorally assess the presence of tinnitus in animals. These methods allow us to pinpoint tinnitus to certain regions of the brain. Another important advancement that has occurred mostly through the use of animal models is the discovery that tinnitus is a result of brain plasticity or disorganization of the brain. And these developments have led the scientific community to understand that tinnitus is a disorder of brain function and not a disorder of the ear that has been the common misconception for decades. So while noise overexposure is still the #1 cause of tinnitus, it can also develop in the absence of hearing loss, in absence of hearing damage, and because of the result of head and neck injury. Tinnitus is the #1 service-connected disability for returning veterans from Iraq and Afghanistan and elsewhere. And as mentioned in the introduction, so tinnitus in these veterans is most often the result of extreme noise exposure from either a single impulse or the accumulation of noise exposures. However, head and neck injury is also a leading complaint of these veterans. In fact, lumbosacral or cervical strain account for 23 of service-connected disabilities for Iraq and Afghanistan veterans. And so in addition to these factors that cause hearing loss, there are other factors that result from somatic insults, including lumbosacral and cervical strain. Research into how these systems interact in the brain has the potential to lead to treatments such as tailored devices that aim to ameliorate the aberrant brain circuitries resulting from both a combination of hearing loss and head and neck injuries. When you consider the costs that have already been mentioned, for disabilities. And in comparison to what is being spent on tinnitus research in the U.S., there is a severe disconnect. Up until very recently, the amount of money being spent on tinnitus research has been negligible and amounts to about $10 million most recently, which is up from $5 million in 2005. But still, it's not nearly enough to address disorders that affect so many millions of people. I'd like to just quickly address that the current treatments that are offered in the VA. And while we applaud the efforts of the VA, current treatments that are offered as part of the Progressive Tinnitus Management Program, while applaudable, are not addressing issues that have been highlighted through research. For example, they use sound therapy as their only treatment, which is not effective for many patients. And so because of this, this is why expanded research is necessary to move forward and use the discoveries that are being made throughout the United States in laboratories as we speak. So I would like to urge you to passage this legislation, and this important one, H.R. 1443. This will go a long way to helping us achieve our goals of improving tinnitus treatment and ultimately finding a cure for this disorder. Thank you.
Thank you very much for your testimony. I really appreciate it. Mr. Adesanya, I think you're up next.
Thank you, Chairman. Ranking Member Brownlee, members of the subcommittee. On behalf of DAV and our 1.2 million member who are wounded and injured veterans, I am pleased to provide our views on the legislation that's on today's agenda. I'd like to highlight two bills to the subcommittee, the first of which is H.R. 1702. This bill would provide VA a renewed and permanent authority to transport individuals in connection with receiving VA benefits and services. As mentioned earlier, previously enacted law had prompted VA to initiate the Veterans Transportation Service, or VTS, which, were it not for the expiration of its one-year statutory authority, would have expanded to all VA locations by 2015. Now, DAV believes VTS can be an ideal partner with our transportation network, the DAV Transportation Network, or DAVTN. While the DAVTN continues to show tremendous growth as an indispensable resource for veterans, VTS serves a special subset of the veteran patient population, one which our transportation network is unable to serve. And that deals specifically with veterans in need of special mode of transportation because of their certain aspects of their conditions. We believe that with a truly collaborative relationship, the DAVTN and VTS will meet the growing transportation needs of ill and injured veterans in a cost-effective manner. Now, as this subcommittee may be aware, VTS operates on funds that would otherwise go directly to medical care for veterans. Thus, our current support for this bill is based on the progress gained through our working relationship with VA to resolve weaknesses that we have observed with VTS. Like VA, we want to ensure VTS will indeed work in concert with all existing and emerging transportation resources for veterans who need VA care, and to guard against fraud, waste, and abuse of these limited resources. The second bill is the Long-Term Care Veterans Choice Act, which we support, based on our national resolution calling for legislation to expand VA's long-term services and supports for service-connected disabled veterans. Established in 2000 and operating under the same authority as VA's Community Residential Care Program, VA's Medical Foster Home approves private home and the caregiver to care for no more than 3 veteran residents in any one location. Caregiver support is provided by the medical foster home attendant. They are provided training, and it is required that these attendants have a secondary respite option. Medical care under the medical foster home is supervised through VA's home-based primary care program, as well as VA spinal cord injury home care program. Patient participation in this program is voluntary, and veteran residents report very high satisfaction ratings. A lot of veterans that we hear from who would like to go into medical foster home are unable to do so, simply because veterans must pay out of pocket for both room, board, as well as caregiver services, and that amount ranges anywhere from $1,500 to $4,000 a month. even veterans who are otherwise entitled to the more costly long-term nursing home care paid fully for by VA, either by law or policy, cannot get in because they have no means to pay. The Navy is pleased with VA's innovation by offering the medical foster home program as one part of its long-term services and support portfolio. And we applaud the intent of this draft legislation to give VA the authority to enter into agreement as well as contract with a VA-approved medical foster home, as well as pay for the room, board, and caregiver services. Mr. Chairman, DAV believes favorable consideration of this draft bill is a good first step for this subcommittee to ensure veterans have access to a full array of home and community-based long-term services and supports. Oversight by the subcommittee is sorely needed as VA endeavors to shift more of its resources away from nursing home care in order to serve more veterans in a cost-effective manner while honoring their preferences and how they live the rest of their lives in light of their impairments. We urge this subcommittee to ensure VA innovations in home and community-based services are not stifled, and that VA's long-term services and supports provide the broadest array of assistance as possible, regardless of age, to those veterans who have lost the ability to function or maintain independence in their community. Mr. Chairman, we look forward to working with the subcommittee on these two bills and for its passage. I'd be happy to answer any questions that you or other members of the subcommittee may have. Thank you.
Thank you, Mr. Adesato. Mr. Drexler, your testimony, please.
Good morning, Mr. Chair and members of the subcommittee. My name is Rob Drexler, member of the Board of Directors for the International Code Council. I also serve as fire marshal for the town of Greece in New York. With 26 years in the building and fire code profession, and have participated in both the NFPA and ICC code development process. I'm pleased to be here today to discuss the importance of compliance with building and fire codes, speaking on behalf of over 50,000 building and fire code officials and other professionals across the United States who are the members of the Code Council. The Code Council was formed in 1994 as a nonprofit organization dedicated to developing a single set of comprehensive and coordinated national model codes, construction codes. The founders of the ICC were BOCA, ICBO, and SBCCI. We joined these three groups together and published a single code for the United States called the International Codes. In 2003, the International Code Council became the successor organization to the three legacy code groups. We now celebrate our 10th anniversary. Today, our international model codes have been adopted at the state or local level in all 50 states. In the District of Columbia, numerous federal agencies, including General Service Administrations, the Department of Defense, and the Architect of Capital, have implemented the I-codes, as have Puerto Rico and the U.S. Virgin Islands. The Code Council's 50,000 members and over 300 chapters include state, county, municipal code enforcement, fire officials, architects, engineers, builders, contractors, elected officials, manufacturers, and other construction industry professionals. I come before you today to encourage support of H.R. 2065, the Safe Housing for Homeless Veterans Act, sponsored by Representative David McKinley of West Virginia and Representative Grace Napolitano of California. Those of us who work to achieve building safety at both the state and local level appreciate the concern that this bill has for the welfare of our veterans who are living in housing subsidized by the Department of Veterans Affairs. In the building sector, the IRC, the IBC, and the IFC established the basic requirements for building safety at the time of construction, and in the case of the fire code, at the time of annual inspections. The codes assure that when faced with hazards including fire, windstorm, flooding, and normal or daily use, the building will allow for residents and users to survive and the first responders to safely rescue building occupants and minimize property damage. Around the country, either at the state or at the local level, both the IBC and the IFC assure that buildings used for residential care and housing are safe. Local code officials around the country inspect veterans' homes and assure that they meet current code requirements, just as they do with any other building within their community. Michigan, as well as 42 other states, have adopted both the IBC and the IFC. In fact, all 50 states have adopted the IFC, while a significant number also adopt the Life Safety Code, which is the LSC. H.R. 265 wisely does not attempt to mandate one code or the other for compliance, but facilities approved by the Department of Veterans Affairs for reimbursement, but requires a certification for all homes that they meet either the IBC, the IFC, or the LSC, which are functionally and for a safety standpoint equivalent code requirements. In addition, the bill does not impose any onerous administrative burden on the Department of Veterans Affairs, only then to assure that each facility receiving reimbursement has obtained a certificate of compliance from the local code official or from a competent third party. This requirement mirrors similar requirements for other medical facilities that must provide assurance to the Centers for Medicaid and Medicare. I only had a few moments this morning to review the statements that will be presented by the VA today, but I would respectfully disagree with many of the talking points in that statement. It is true that veterans' homes covered by this requirement that are located in jurisdictions that does not adopt and enforce either the IFC or the LSC, there will be a small additional burden of obtaining an annual inspection. However, it is the clear intent of the bill sponsors and a worthy goal in our opinion that our veterans who sacrifice so much for our freedoms should be provided with safe housing, especially when the taxpayer is subsidizing that housing. It's hard to argue that our veterans should not be assured of minimal safety in their home when the cost of assuring safety is only a couple of $100. In closing, the International Code Council is proud of our work in developing the model codes to assure basic level of safety in the built environment, and we applaud your efforts to use those codes to protect the safety of our veterans. I respect the work of your subcommittee and encourage continued collaboration between the public and private sectors to achieve the important goal of increased safety in our nation's buildings. Thank you very much for the opportunity today, and I'd be happy to answer any questions.
Thank you, Mr. Drexler. Mr. Kelly?
Mr. Chairman, members of the committee, on behalf of the men and women of the Veterans of Foreign Wars, thank you for the opportunity to testify today. The VFW supports H.R. 1443, which would require the Department of Veterans Affairs to recognize tinnitus as a mandatory condition for research and treatment by the VA Auditory Center of Excellence in coordination with the Department of Defense Hearing Center of Excellence. Although there is no known cure for tinnitus, it should not be assumed that the condition is untreatable. VA's progressive tinnitus management approach, which assists tinnitus sufferers through individual counseling and support, is helping veterans better manage their symptoms. Still, more research is needed in order to identify truly effective treatments in alleviating these symptoms. This bill represents a positive first step towards achieving that goal. The VFW supports H.R. 1612, a bill that directs the Secretary of VA to convey a parcel of land to Tuskegee University. More than 90 years ago, Tuskegee University donated the land, nearly 300 acres, to the United States government to build a veterans hospital. Today, 21 of those buildings, accounting for nearly 280,000 square foot of space, sit vacant on that property. Annually, VA spends approximately $2 a square foot to maintain vacant space. For the building that fall within this land transfer, VA spends more than $500,000 a year in maintenance. Reducing the financial burden for upkeep of these buildings and grounds will allow VA to better use those funds to ensure the highest level of maintenance for the facilities to provide care and services to our veterans and not to buildings that are sitting vacant. The VFW supports H.R. 1702, which permanently authorizes the Veterans Transportation Service, or VTS. This program, commissioned by the Office of Rural Health in 2010, has greatly improved access to care for rural and seriously disabled veterans by allowing VA facilities to establish and coordinate a network of local transportation providers. In 2012, the program was temporarily suspended following a determination by VA Office of General Counsel that VA lacked the statutory authority to hire paid drivers to transport veterans. Congress wisely passed a one-year authorization of VTS program in January of 13, but a long-term fix is still needed. This legislation would guarantee the continuation of and further expansion of VTS, which plays a critical role in minimizing the challenges many veterans face in traveling to their appointments due to physical disabilities or great distances. The VFW supports H.R. 2065, which would require facilities that house homeless veterans to meet the relevant local building codes in order to receive per diem payments under VA Homeless Providers Grant Per Diem program. Currently, VA is required to check housing certificates before awarding grants for housing services provided to homeless veterans. However, thorough checks of fire and safety requirements, as well as structural conditions of buildings, are often overlooked. This bill requires that current recipients of the per diem payment submit certification of compliance with local codes within 2 years of the enactment of this act, giving them ample time to make the necessary improvements. The VFW believes that VA funded transitional housing must be safe, secure, and sanitary. This bill will ensure that those standards are met, providing homeless veterans with the best chance of successful community reintegration. The VFW supports the Long-Term Care Veterans Choice Act, which would add language to Section 1720 of Title 38 to allow veterans to receive VA care and require protracted period of nursing care to provide transfer into adult foster home at their request. To grant VA the authority to reimburse adult foster homes would provide veterans with the additional residency choice, potentially improving the quality of life for those who would prefer this option. The VFW strongly believes that all non-VA services should be provided in conjunction with proper care coordination. Currently, VA Handbook 1141.02, the medical foster home procedures, establishes the policies and standards for VA care coordination for veterans who choose to live in medical foster homes. The VFW feels that these procedures would ensure adequate care coordination for veterans who choose to participate in fully funded adult foster care programs. However, these procedures are now set to expire in 2014, and VFW recommends that care coordination policies outlined in that document should be made permanent by adding them to the language of this legislation. Mr. Chairman, this concludes my testimony. I look forward to any questions from you or the committee.
Thank you very much for your testimony. Well, we have the chairman of the full committee. Would you like to discuss your piece of legislation before we get to the questions?
If I could, I appreciate it. I didn't walk in here to automatically start talking about my piece of legislation, but
if it's all right with the committee, we'll let the chairman go for 5 minutes.
Thank you very much. I appreciate it, Mr. Chairman. Thank you to the witnesses. I apologize for stepping in front of the questioning, but I want to talk to you about a long-term Veteran Care Choice Act, and I think it's something that this committee can certainly get behind and support, because this act would authorize the Department of Veterans Affairs to enter into a contract or agreement with a certified medical foster home to pay for the residential long-term care of service-connected veterans who are eligible for VA paid nursing home care. As a component of such care, eligible veterans would also be required to receive VA home health services. VA or medical foster homes, for those of you who don't know, are private homes in which a trained caregiver provides 24-hour around-the-clock care to a few individuals. They are designed to provide a non-institutional long-term care alternative to those who prefer a smaller, more like home setting, one that they are more accustomed to in their own homes than traditional nursing homes are able to provide. VA has been helping to place veterans in medical foster homes now for well over a decade. VA, as a part of the placement process, inspects and improves all MFH limits care to no more than 3 veterans at a time, and provides care to veterans living in such homes with home-based primary care services. They also provide safeguards to ensure that veterans themselves are safe, and that they receive high-quality care by requiring the MFH caregivers to pass a federal background check and VA screening and agree to undergo annual training. And they also allow VA adult foster home coordinators and members of a VA home care team to make both announced and unannounced visits. Today, according to VA, over 400 approved caregivers provide this type of care in their homes to over 500 veterans daily in over 35 states. The problem is, however, that VA does not have the authority to pay for the cost of this care. So the veteran who chooses to live in a MFH must pay out of pocket with their own personal funds, regardless of whether or not such veteran is eligible for VA paid nursing home care. What this does is create a situation where many service-connected veterans with limited financial resources who would prefer to live in a medical foster home go to a nursing home institution instead, because VA will cover the cost of the nursing home but not the foster home. And while traditional nursing homes will always be a vital component of long-term care, medical foster homes provide a worthy alternative for many of our veterans. According to the department itself, many more veterans would elect to receive care in a medical foster home should VA be granted the authority to pay for such care. And I'm sure we all agree that one thing we owe our veterans, particularly those who are service-connected and in need of long-term care, is the luxury of choice. The choice to decide whether and how they receive care where they need to receive that care. And as the veteran population continues to age, the need for long-term care services will in fact continue to grow. The Long-Term Care Veterans Choice Act would expand the long-term care choices that are currently offered to veterans beyond traditional services. Now, additionally, in being beneficial for the health and the well-being of veterans, the average cost of a medical foster home is more than half the monthly cost of a nursing home, making this legislation a very cost-effective health care option. This is a common-sense, veteran-centric bill that will free many veterans from financial turmoil and allow them to make their own decisions about what kind of long-term care they and themselves want to receive. I look forward to working with all the interested parties to resolve any issues they may have during today's discussion. And Mr. Chairman, thank you so much for allowing me the opportunity to talk about this particular piece of legislation at today's hearing. And I also want to personally thank you for your hard work as chairman of this subcommittee. It's very critical work for the veterans of this country, and your leadership is greatly appreciated, and I yield back.
Thank you, Mr. Chairman. I'm going to yield myself 5 minutes for a few questions for the panel. Dr. Shore, I have a great interest in this, in tinnitus as well, because I realize it's a very prominent and probably the most frequent disability that we see from our veterans returning home now. But there's been a couple of questions, and let me just read it. Several veteran service organizations with the independent budget raised concerns about protecting and preserving the VA research funding decisions by the scientific merit-based peer review process without interference from outside stakeholders. Please comment on that concern. Do you feel that this would compromise in any way the current peer review system already in place?
I'm not sure what you're referring to by outside.
Well, I think that I think the VA contends that they have a peer review process for determining how to fund research, and they feel that outside influences like Congress directing the way that we conduct research would take away from the the peer-reviewed medical decision-making process of determining where the funds should go.
Right. No, I don't agree that it would. Yeah, I see where you're coming from. I don't think that it would interfere with that. I think it would enhance that process as long as you have people that you're deferring to or consulting with who know something about the way tinnitus works.
Right.
So.
What's the current funding level for tinnitus research?
It's about $10 million everywhere.
That's the total in this
Yeah.
country, $10 million a year for the research in tinnitus? Or is that just the VA?
Yes, no, that's the total. So that's much, much, much lower than it should be. So we have increased the funding from what it used to be 5 years ago. NIH is now recognizing tinnitus as a separate disorder that needs to be considered for funding. The DoD is also putting forth opportunities for people to submit grants to study tinnitus, but it still isn't nearly enough to bring the research into reality, because it takes a long time for our research finding to then be taken into a clinical trial. And we don't want to take research findings into clinical trials unless they've been proven in the laboratory. So it takes a lot of money for research to end up helping patients.
Well, no, I realize that amount seems very small considering the number of veterans that are coming home with
It's
problems.
extraordinarily small. Yeah.
Especially in view of the fact that we don't really have much in the way of treatment or understanding of the disease.
Right.
So,
Well, I think it's progressing, but we're not there yet. I mean, there has been a lot of progress in the last decade. And as I said, one of the big jumps was in recognizing tinnitus as a brain disorder and not just a disorder of the ear.
Right. I didn't realize that myself.
Yeah, so it is often triggered by damage to the ear. But the reason that it's a brain disorder is because the brain reacts to the lack of input from the ear. And it starts doing its own thing, which is what produces the tinnitus.
Right.
And many systems within the brain are acting together. And so treatments have to involve things other than just sound therapy, which is the most available treatment, but not really very effective, and in some people not even effective at all.
Right.
So now there's the development of devices that take into account other etiologies than just the ear. For example, the somatosensory side of things, which is going to be even more prevalent in the veterans population than it is even in the normal population, because they get head and neck injuries as well.
Right.
And so the hearing loss combined with the head and neck injuries, which themselves can cause tinnitus, makes,
I
the reason.
I think you explained that we need a little more research in this department pretty well. And I just want to get to one other topic before my time runs out. So I thank you for your answer. Mr. Gadd or Mr. Kelly, I have an issue with this VA transportation in rural areas. I have a representative of rural northern Michigan, and the DAV vans are being manned by more and more elderly veterans, and we have a difficulty in providing adequate transportation for veterans. Well, I guess my concern about the VA, I want to be sure that we use that money very efficiently. Like some of you mentioned, that money is being diverted for transportation away from patient care. So how do you think that we should do oversight? I mean, I kind of get concerned about the fact that we hire a driver, we buy a van, and then they sit there for 80% of the time, or maybe we should be contracting and, how do we oversight that so it's an efficient system within the VA? Mr. Gadd, do you have a question or an idea, Mr. Kelly?
Sure, I can respond to that, and thank you for the question. So I believe it was mentioned earlier, and the VA will have their particular figures on the cost savings, but when these mobility managers came in with the VTS program, they really aligned, they worked together with beneficiary travel. And so there was some reduced cost savings from beneficiary travel. And, in addition to that, they were developing a tool to be able to manage the cost and looking at cost and trying to reduce the cost. The other part that was mentioned earlier was about special mode transportation. And this, the VA would have the contract with third-party providers to, provide that transportation. But if they're able to have the ability through the VTS program to do that in-house, there would be some reductions in cost there. And then two, it just makes sense because it's one additional option that, if Veteran Service Organization drivers can't take that, van or to that veteran, and they're outside of an area where transportation is not offered, that it could reach those particular veterans. So we see it as a win-win for veterans. Right.
Mr. Kelly, do you have any input there?
I'll just echo a sentiment. Beneficiary travel is hard to have oversight of. Veterans come in, make a claim that they traveled to their appointment. VA submits or receives the claim and provides a check in return. With this, I think it would be easier to do accountability. If you have a contractor who says, we went to pick up these 10. There's evidence of that they brought them to their appointment and then took them home. So I think in the long run the oversight would be much easier doing this VTS than beneficiary travel. So and I think Mr. Gadd said there's evidence that it will be a cost savings.
Thank you, gentlemen. I've overstepped my time a bit, but Ms. Brownlee, do you have questions?
Yes, thank you, Mr. Chair. I wanted to go back, Dr. Shore, and ask you a few more questions about tinnitus. I said tinnitus, but I'm going to now say tinnitus. I'm happy to hear that actually NIH and DOD are getting involved in recognizing this as a serious problem. I'm interested to know. You talked a little bit about the research or the lack thereof, but I'm interested to know where the promising research is. You talked about damage to the ear, the brain being two possible causes for this disease. Is the research going more towards being more directed to brain research, or?
Yeah, I think the strong research that has begun over the past decade or so has been targeting brain mechanisms. And so there are many laboratories now around the country. Some of them do imaging studies with humans. Many of them use animal models, because with animal models, you can go into the brain and record from single cells and see what happens to those single cells after a noise exposure or after head and neck injury. And so a lot of our understanding has come from those animal models that show that especially after noise exposure, which is a lot of where the studies focus on, the neurons in certain specific parts of the brain become hyperactive. So they're firing along as if there were a sound there. And higher neurons up there are interpreting that as a sound, whereas in fact there is no sound. And then another thing that has been discovered is that it's not only auditory centers in the brain that are involved in tinnitus, but non-auditory centers as well. Some of those I've already mentioned, such as the somatosensory system. So many people who have tinnitus, if they clench their jaw or push on their face, they can make their tinnitus louder or softer or change the frequency or even make it go away. And that highlights this interaction between this touch-sensitive neurons and the auditory neurons. Another area of strong research over the past few years has been the connection between tinnitus and depression. And it's often comorbid, again, in disorders such as PTSD. And it could be that the reason for that is because the brain mechanisms are targeting both of these centers. So it's not necessarily the chicken and the egg stories. It may be that these conditions develop together, and you don't just get depressed because you have tinnitus, but that depression and tinnitus sort of exhibit themselves together. And so some of the research is targeting those areas. And I could go on for a long time.
But the damage to the ear, then, it seems to me, as someone who doesn't have a medical background or a science background really at all, it seems if there was damage to the ear, that is something that could be fixed, that perhaps would be a cure. So it seems to me that it is much more on the brain.
Yeah, so one of the big questions with tinnitus is that even some people who have noise damage and hearing loss don't get tinnitus. And why is that? We need to understand that. Because if we understand that, maybe we could prevent the people who do get tinnitus from getting it. But even if somebody doesn't have a hearing loss, they can get tinnitus. And that's been a big area of research recently, because audiology clinics can measure and show, they can show that people don't have hearing loss. But if you do more sophisticated hearing tests, you can show that hearing actually is affected at a much milder level, enough to trigger tinnitus in the brain.
Thank you. And any research, we've talked about the research in the United States, or is there any research outside of the United States internationally that is any different than what you've just discussed?
Well, there are some research organizations outside of the U.S. that have actually been very instrumental in pushing tinnitus researchers forward even within the U.S. And some of them are based in Germany and England, and they're trying their best as well, separately and together, to try to push tinnitus research forward so that we can find a cure.
And is there some coordination that we're doing between investments in the research now that other agencies, NIH, and you said DOD is providing some grants, and what the VA is doing?
Coordination in what sense?
Well, coordination and in terms of, progress or the research that needs to be done before, to pursue a clinical trial.
Right. Well, there are scientific meetings that are very important that, most people who do research in tinnitus will go to those meetings and present their findings and have discussions, set up collaborations. And that is the major source of information transfer as well as publication of papers. And that's going to be available to everybody, not just within a certain organization.
And of our veteran population that's suffering from this, do you have some percentage of our veterans who we just haven't provided any kind of successful treatment for it?
Well, I think the majority is not getting really successful treatment because there is no cure. And I mentioned that there is a treatment program that's available. That does help, I think, to some extent, because even a person who comes in who has tinnitus, if they're told that this isn't due to some life-threatening condition, that makes them feel better. But that doesn't make their tinnitus go away. Sound therapy is like masking. It sort of masks out the tinnitus for some people some of the time, but it's not actually getting rid of the tinnitus. And so currently there aren't any standard treatments that we could say everybody should use this and their tinnitus will go away. But there are a number of tinnitus treatments that are being developed in research labs, that are being tried out in animal models, and that are being moved for clinical trials. And some of those are extremely promising because they're targeting the root of the disorder and trying to change brain circuitry.
Thank you, and thank you for the additional time. I yield back.
Mr. Hilskamp?
Thank you, Mr. Chairman. A quick question first for Mr. Drexler. You do mention a few of the rural areas might not have a code that you referred to, and then how are those situations handled in your mind? How should they be handled in terms of these inspections? Who would inspect, and what would be the basis for those inspections?
Essentially, the firm would hire a third-party inspection agency, and that is becoming very common across the country. The simple example would be the state of California. We've all gone through the economic downturn, and California really took a big hit, and they were forced to reduce numbers within their building and fire prevention staffs, inspection staffs, and went and began hiring third-party inspection agencies. Third-party inspection agencies would provide those inspections. They meet the certain qualifications that's established by and within the municipality, and would ensure that.
But Mr. Drexler, quick question: if there is no code specified by municipality, or the county, or the state as a mandate, what should be the code for the basis of the inspection then?
What should be the code if there's no code within that municipality? I think the legislation here would draw the need to require either the I-codes or the life safety codes, and recommend and require those codes to be in place within the municipalities that don't have building and fire prevention codes.
So the municipality would be forced to adopt those?
Yes.
Under this legislation. Okay, well, thank you. One other question, though. I appreciate that. Follow up on a little bit more on the transportation issue. I did a town hall in Syracuse, Kansas 1 week ago or 8 days ago. Same gentleman was there a year ago, brought up the same story again. I'm sure you hear that from rural areas. In this case, he was asked to drive 524 miles to have blood drawn. And it's just crazy. I can't get the VA to figure out that there's a dozen hospitals along the way, including one in his hometown. And here we are talking about encouraging transportation. All we're encouraging him is to allow him to go a few blocks to the local hospital. What should I tell this veteran? What do I need to be doing? I can't seem to get the VA to figure this out. He's mentioned that to him. Again, 524 miles to get his blood drawn. And it doesn't matter whether you have contract, the issue of who drives him, it's himself. And as long as he drives, 3 times a month, he can be reimbursed, but not if he drives less. Any thoughts that from the veteran service organizations? What are we supposed to be doing here? This is just unacceptable, and I can't get an answer for him that works. Mr. Gudd?
That question. I think that we testified, American Legion did in the fall last year about fee basis and non-VA care coordination. And, we said that the VA should exercise discretion based on patient-centered approach. And that approach is that, we can understand if they go for a major procedure within a visit or within near an area, but to have multiple trips a couple of days a week, for dialysis, that look at other options closer to that veterans community. And I think that that's a perfect way to in this case, what was the local options? What was the closest community-based outpatient clinic? Is there demand for laboratory services there in that area? Maybe that's something that the gentleman from the VA could address this morning. So, but we would argue that if it's multiple trips and it's inconvenience, that the VA does have that authority to allow that veteran to be treated there locally near his home.
Do you think they have in your mind, they don't want to allow that, or it gets lost in the shuffle, or they just generally do not want to allow that? What's your thought on the VA's?
They implemented the non-VA care coordination as the new rollout of that program, and they're trying to standardize procedures and how they formulate those decision-making abilities of, but we've argued that the veteran should have a say in that process, and that there should be some recourse that the veteran has to appeal that decision, and not have to drive 500 miles to get a blood draw. And, it's ridiculous.
Either Mr. Keller or Mr. Altosano, any thoughts?
I'm just going to echo what Mr. Gabb had mentioned. That local VA facility, the parent facility that veteran's driving to, has the authority to pay for that service or that lab service at the closest location to the veteran's residence. There are various reasons why a facility would choose not to exercise that authority, and I don't think we can discuss that at this point without all the information in front of us, but nonetheless, that veteran should be able to speak to their primary care physician, their social worker, and hopefully that healthcare team will say, 500 miles is a little too much. But again, I can't answer one way or the other why that is. That's to say that VA does have the authority. Is
this a situation you hear about with regularity? How often does it happen? Is it just one guy in Syracuse, Kansas, or is it something that you continue to hear from your constituents about as well?
Well, as far as getting care in the community, we hear it more often simply because it is an issue that is brought up, as opposed to a veteran who does get care in the community doesn't say, hey, I got care in the community, it's great. They have nothing to contact and complain to us about. But so there are issues like that where a veteran is not being allowed by VA to go to a local or community service and have VA pay for it, which is not to say that the issue of transportation is without this kind of issue as well. But it is an issue. And that's why VA, as Jacob mentioned, has a non-VA care coordination office set up to establish some semblance of compassion in the fee care program to make it more patient-centered.
Okay. Thank you, Mr. Chairman. I appreciate it. Unless Mr. Kelly had some follow-up. Thank you. I yield that.
Well, I'd like to thank the members of the panel for their testimony today. It was very enlightening, the different pieces of legislation we covered, and I do appreciate your your comments and look forward to any further input you want to give to me in the future on this bill. So thank you very much for your participation, and you're excused. We'll now call Dr. Jesse, as he's the sole member of the third panel. You can begin when you're ready, Dr. Jesse.
Good morning, Mr. Chairman and Ranking Member Brownlee and members of the subcommittee. We do appreciate your continued efforts to support and improve veterans' health care, and we thank you for the opportunity to address the bills on today's agenda along with their impact on VHA's healthcare operations. Joining me today is Deputy Assistant General Counsel Susan Blauert, and I'd also like to thank Chairman Miller for coming by earlier. VA recognizes the importance of each one of these bills, and we are committed to work with you and the members of the subcommittee and Congress on legislation that can enhance our ability to provide health care to our nation's veterans. I'm going to address a few key points on each of the bills today, but the more detailed explanations are available in my written statement. Regarding the draft Long-Term Care Veterans Choice Act, VA supports the concept of medical foster homes as an alternative to long-term institutional care as requested in VHA's FY 2014 budget submission. We appreciate your interest in the concept, but we do need additional time to continue technical assistance to the committee, in particular on details pertaining to the term adult foster home versus medical foster home, the payment methods and cost analysis. VA strongly supports HR 1702, which would make permanent the authority to hire qualified drivers to expand VA access to VA healthcare for individuals traveling to and from VA healthcare appointments. In 2012, the Veterans Transportation Service, or VTS, provided more than 199,000 one-way trips totaling more than 9.7 million miles. The average length of one-way trip is over 48 miles, and that's a considerable distance and often would be prohibitive for those with poor health were transportation not available. Veteran service organizations are invaluable in providing volunteers to drive veterans to their appointments. However, there are often not enough volunteers to meet the level of need. More importantly, they're often precluded from transporting veterans with various clinical issues, such as portable oxygen, as you heard. We do not see VTS as competitive, but rather supplemental to the important role played by the VSOs. VA is in agreement with the goal of HR 1443, the Tinnitus Research and Treatment Act of 2013, which would recognize tinnitus as a mandatory condition for research and treatment and require cooperation with DoD to perform further research. However, the bill describes programs and operations that already exist within VA. Our audiology clinics already provide tinnitus treatment through a progressive tinnitus management program, which includes group educational counseling treatment and individualized management. VA has active projects underway in researching the efficacy of this multidisciplinary tinnitus treatment, the underlying etiology of tinnitus, and the co-occurrence of hearing loss along with tinnitus. VA is also collaborating with DoD on the development of a registry of the critical information to track the diagnosis, surgical interventions or medical treatments for tinnitus, and to follow up for each case of hearing loss and auditory system injury incurred by service members while on active duty. Currently, VA has a responsibility to ensure the safety of veterans cared for in its grant and per diem or GPD facilities through on-site inspections of each facility by staff from the local VA medical center. Inspections are focused on compliance with the requirements of the Life Safety Code of the National Fire Protection Association. The inspection team is responsible for ensuring that general operating requirements, as noted in GPT regulations, are met. VA believes these measures ensure the safety of those properties, and recognizing that is the intent of HR 2065, we do have some concerns with the bill as written. Specifically, we're concerned that HR 2065 will shift the cost of certifying compliance with Life Safety Code or other applicable codes to the GPD grantees. Currently, VA covers the cost by inspecting the GPD facilities for compliance with Life Safety Code at no charge to the grantee. Over 96% of current GPD projects are operated by nonprofit community-based providers. Any increased operating costs for these grantees could have a negative impact on the type and quality of services provided to veterans. We are also concerned that HR 2065 could have an inequitable impact on GPT providers in rural areas because of the difficulties of assessing qualified inspectors to certify compliance in those areas. We do not yet have testimony on HR 1612, which would authorize VA to transfer a 64.5-acre tract to Tuskegee University, or as noted previously for the draft Long-Term Care Veterans Choice Act. However, we look forward to working with the committee in providing technical assistance on these and any other bills before the committee today. This concludes my remarks on behalf of the department. Thank you again for the opportunity to provide our views and be pleased to answer questions.
Thank you, Dr. Jesse. It's a pleasure to see you once again before the
Thank you, sir.
The committee. I have a couple of questions. I'll yield myself 5 minutes. So is there a difference in what you're saying about the amount of research in tinnitus? I mean, you said you're already doing things, but it didn't sound like you weren't doing research, because I think this $10 million number is what keeps sticking in my mind, that there's so many episodes of tinnitus, and you had $10 million for a multi-billion-dollar problem. It doesn't seem like much, but you seem to say something that you're already doing something about it. Is that $10 million number wrong? And there you saying?
Well, that $10 million number, I think, Spoon, was nationally, not just VA nationally. VA's investment is about $1.2 million, so about a tenth of that is in VA, mostly in 4 projects. 3 of which I really focused on the clinical assessments. One specifically, which was called for in the bill to look at the efficacy of this multi-step treatment program.
You don't dispute that number, then? That number seems reasonable to you. That's the point I'm trying to.
No, I actually think that's a pretty small number compared to what we spend on a lot of other things. And I think what's interesting is, as Dr. Short noted, that there's really been I think a dramatic change in the past, I'll just say a couple of years, through new imaging modalities that are really beginning to describe the functional changes within the brain in patients with tinnitus, historically, which is really focused on it being an ear problem. And but those technologies are relatively new, and it takes time to get that kind of work into the life cycle of research. But yeah, I think I don't know. I guess I don't know that I can say it's underfunded because there's not enough money for the research, or it's underfunded because there's not been the kind of high quality grants proposals coming through the system in order to get them funded.
So it sounds like you're in favor of the legislation.
Well, we have no problems with the legislation. I think basically what's described in legislation is stuff that we're already doing. I guess the one issue, and just to be very clear, because of the dynamics of research, is remember that VA is only authorized to do intramural research. We can't fund extramural research. That's one of the reasons why we value the research partnerships with DOD, who can.
Okay.
And I don't have the numbers for DOD-based research there.
Well, that's an interesting point there. Yeah. I have another question for you too, and that is this transportation issue. Mm-hmm. You know what I mean? And that's something I think we may have talked about before, and that is the fact that it came out here in the earlier panel with Mr. Hulskamp pointing out the fact that are we going to transport more patients, make it easier to transport the patient 500 miles, or are we going to use the local community access mode and the balancing of that? You know, I mean, I've been to town hall meetings myself where veterans have said to me, I can't get to the place I want to go to get my x-ray, and the other guy said, well, you can get the x-ray right here. One veteran wants to go with the 100 miles to get the chest x-ray, the next veteran doesn't want to go with the 100 miles to get the x-ray. He wants to get the x-ray. So I know there's a lot of individual variability in the patient preference. And I don't really know the best answer to that myself. I think now it all happens at the VA. My concern is the fact that does the patient have an opportunity to call back once he gets an order to come in for an x-ray or a blood test? Can he say, he can just call the VA back and say, can I get the test done at my local hospital without having to go back to the initial doctor? Because sometimes that could be the problem, you know, then the person who's answering the phone from can't get hold of the regular doctor, or, you know, doesn't have the authority to make that decision. I mean, I think in the practical terms of how that gets done, there may be some problem. You know what I mean? When the patient says, I'd rather get it done in my hometown, and then the person they talk to on the phone doesn't have the authority to do that and can't get hold of the person that does. And how does that actually occur to make it better for the patient?
So I think this is one of the reasons why we're, as Jacob Gadd mentioned, the notion of having the coordinator for non-VA care. So there actually is a person who can make these kinds of decisions without somebody getting into the swirl of administrative phone tag. I know my patients, some that live, so in Richmond, where I still have my clinic, we draw from northern, you know, down into Roanoke Rapids areas, North Carolina, and the far southwest Virginia. Some people have to travel fair distances. I mean, I think the common sense is the one thing that ought to prevail here. And I have patients who, for instance, on warfarin, who have to have their INRs checked. Most of them will get it checked locally, and they'll also get it managed locally. Occasionally, people will get it done at the VA because they're coming up for a lot of other things, and we can coordinate the visits around that. I think traveling 500 miles to get a blood drawn is kind of beyond common sense. I mean, if you're looking at a cost basis, what we pay for Beni travel far out exceeds the cost of that test. And the other piece that comes in here, and one of our real fears many times, is the lack of coherence of the information, meaning if it's done in the VA, we track it through our electronic medical record. It's there for everybody to see. There really is the continuity of care based on the information. When it gets done outside and gets reported in, it often gets lost. And you know, obviously a lot of what's going on nationally around health IT is meant to take some of those things into place. But I think we really try to do what's best for the patient. And you know, I'm sorry to hear that some people have problems like this. I think that we need to be doing better in those cases.
Do you think that this coordinator, this person, is going to make the difference then? That's what you're telling me?
Well, I think the primary care, you know, as we move to team-based care, as we move to this notion, the idea of PAC, that you now have actually a direct connection in, and you should not be having these I can't get my provider type of things, and those decisions can get made and taken care of that way.
My time is up here. I'll leave it to Ms. Brown.
Thank you, Mr. Chair. I just also wanted to follow up again on this tinnitus and the role of the VA in it. It just, I mean, it seems to me that you know, $1.2 million is not enough for the VA's participation, and it seems to me, if this is something, and clearly it is, that our veterans are suffering from, that the VA should be taking a significant leadership role in trying to lead the research to find cures for this. It's clearly it's costing the VA a lot of money for treatment that doesn't seem to necessarily have great outcomes, and I think always with research, if there's a will, there's a way, and it seems to me that the VA should be the leader in this area.
So I think from a clinical perspective, in the treatment of tinnitus, we are. In terms of the basic research, I don't know that we're not, because obviously there's not a lot going on in the country as it is, but as I mentioned, I think one of the issues is it's been a problem because we can't quantitate it, we don't have a biomarker for it, and we don't have a cure for it, so because we don't really understand in many cases what causes it. And so we've had to focus on the treatment and amelioration of the symptoms. Now with newer imaging modalities and better science, I think we're going to get a much better handle on the basis of the disease. And then when one can understand that, you can begin to define treatments that get to the root source rather than treating the symptom.
Well, if we were, I mean, in Dr. Shore's testimony anyway, it seemed as though the treatments generally aren't as successful, I guess, as we would like them to be. And if that's our leadership, it doesn't seem to me to be adequate, because we're not necessarily treating the condition successfully, and yet we also don't have a cure. So it just feels to me very much like we should be in a better leadership role around this, because it's our customers, it's our constituents who are suffering from it, and we shouldn't be dependent on sort of outside research in hopes of coming up with a cure. I also just wanted to ask why at this moment you don't have a position on HR 1612. Is that what I heard you say, that you didn't have a position?
Oh, it's for Tuskegee.
Yeah.
So just to be clear, we have no issue with transferring the land. It's a technical issue about what's required before we can do that. And so so my understanding, without stepping over my knowledge base or bounds on this, is that in order for us to transfer land back, certain assurances have to be made, and those are already existent in other federal statutes. And so those have to be completely vetted and understood, and then we work through the process. Our objection is not in the transferring of the property, it's making it happen in a way that meets all the requirements, and we just have not fully understood all of them yet, and also what that's going to mean is there's going to be some cost associated with it that will have to be borne by somebody. We just don't know what that is yet, and that's why we don't have the views.
Thank you. I yield back.
Thank you, Ms. Brownlee. Well, I think I have so many questions that could go on for a couple more hours. And to tell you the truth, there was a lot of interesting things that came up in all the panels today, and so I maybe put some written questions for the record in the future from even some of the previous panels as well, because it's such an interesting subject and I think deserves a little more thought. So I want to thank you for your testimony today, Dr. Jesse, and thanks to all the other people that testified today. So you are excused, Dr. Jesse. I ask unanimous consent that all the members have 5 legislative days to revise and extend their remarks and include extraneous material. And without objection, so ordered. I would like once again to thank all the witnesses and the audience members for joining us in today's conversation. The hearing is now adjourned.